Assalamu alaikum and good afternoon. Dear physicians, this is 73rd session of ECG lecture series that is organized by ECG study group, ECG Basic and Beyond. Today we have among us one of the most prolific speaker, Dr. Kazi Atiqur sir, and he will discuss case studies in ECG. Before start, I'd like to request Professor Abdul sir to introduce Kazi Atiqur sir among us. Wadud sir.
Thank you, Tushar. Today we are going to have a very interesting session. We're going to have a talk on ECGs in acute coronary syndrome in young patients. The catch point is the young patients. And we are going to have a talk from none other than Dr. Kazi Atiqur Rahman. We go a long way. We are actually from the same year. We both graduated from different medical colleges in 1990. He graduated from Salimullah Medical College. Then he finished his MD Cardiology in 2001 from National Institute of Cardiovascular Diseases. He went abroad and got training there and also got a degree. He got MRCP UK from Royal College of Physicians, London in 2011. Abroad, he has worked in King South Chest Hospital and later on King Salman Heart Center in King Fahad Medical City, Riyadh. And he got wide exposure in different intervention and cardiac problems in that hospital. I hope we are all going to enjoy what Dr. Kazi Atiqur Rahman is going to offer us. Atiq, you can proceed.
Thank you very much. Good evening and assalamu alaikum, all of my colleagues and physicians. I am very delighted that ECG study group, they invited me as a speaker, and I must congratulate them for doing this job for the last more than 2 years, enriching our knowledge and educating our junior doctors also. So today I am going to present some interesting ECG in acute coronary syndrome in very young patients. Here the patients are so young that we cannot think about these things in the Western world also. So I will try to show the ECG and sometimes correlate with the other findings also, some investigational procedure and the coronary angiography and the intervention also. So my first case is 39 years old, young female who doesn't have any major risk factor for coronary disease. She presented with a recurrent chest discomfort and a heaviness for the last 3 years. But her symptoms aggravated for the last 1 month after taking meal only. She was evaluated by different cardiologists for the last 3 years. And all investigation, ECG, echocardiography, and the blood test, including the cardiac biomarker like troponin, CKMB, all are negative in the normal in the last 3 years. So when she first presented to my OPD, for me, her symptoms are very typical. And we did the ECG at the OPD. And this is her ECG. Can anyone find anything abnormal in this ECG? She is non-diabetic, non-hypertensive, non-dyslipidemic, no family history of ischemic heart disease. Only 39 years old, young female.
Tushar, you can invite someone.
Sir, I'm inviting Dr. Abida Tasnim Reza. Dr. Abida, can you highlight anything in this ECG? Dr. Abida, are you there?
Actually, some
Okay.
ST
So,
depression. Yeah. Can you tell Tushar, Dr. Tushar?
sir, to me, apparently, the thing I see, apparently the ECG seems normal,
Normal.
except the 2 and lead 2 and lead AVF, the ST segment looks a bit upward.
Yeah.
Other than that, for me, I don't find any apparent abnormality. For me, sir, I might get wrong.
Yeah.
Hello, sirs. Assalamu alaikum, sir. This is Abida, sir.
Okay, Abida, please.
Yes. May I make some comment regarding this ECG? So
Sure.
currently in this ECG, it seems quite normal, normal looking. But to me, I think, can we say that there is port progression of R wave from V1 to V3, including all the findings like some ST changes in 2 and AVF. Other than that, can we say that as well?
Abida, I will make a comment on that. Actually, when you want to say poor progression, there should be a drastic change between leads. Let's say the P wave is not progressing at all from V1 to V3, then you got a big R wave in V4. But here, the R wave is gradually increasing in size. So we could not say it's poor progression.
And also female patient.
Yeah. For poor progression, you have to have the dramatic change in the size of the R wave.
Yes. So basically, I evaluated all the ECG in the past 3 years, and looks like almost the same ECG, at least 4 or 5 ECG in the last 3 years. So I decided to do some other test. So what should be the next test?
Sir, 39 years old lady must presumably be menopausal age group. So,
No.
premenopausal. Sorry.
Premenopausal, yes.
Premenopausal. So, for me, if the symptom.
Tushar, as a cardiologist, I should always go systematically. After ECG, what the next test should be an echo.
Yes, sir. Echo, as sir said, most probably, if I'm not wrong, echo is normal.
Echo is normal.
I think the way we should do, definitely, first of all, we have to look at that, whether she has any exertional angina or not. Okay. The question right now that the story we're getting that she was having some at the end, probably with meals, right? When she was eating meals.
Yes.
Yeah, that's another concern we have. Because main concern is how we approach to what kind of test you do. Okay. If the patient has low probability, you think in the beginning. Yes. And then if the EKG is totally normal, we don't go initially to imaging study, you go just routine treadmill stress test. But if there's a question about EKG abnormality, then you might supplement with some kind of imaging. In young patients, you don't want to expose radiation, probably exercise stress echo would be better approach to see if any wall motion abnormality you can see on top of that. But if the patient cannot walk,
her age.
Yes, and also with her age and EKG, if there's no EKG abnormality, definitely I would do like ETT first, or actually approaching the patient doesn't have any predictable exertional angina. If the patient has predictable exertional angina, it's already unstable angina. If it's progressing over time and intensity is increasing, then you don't want to do any testing. You go directly for angiogram. But another option that you have high likelihood of that that you have concern about that nowadays. But CT angiogram, we started doing it, but in this case, probably I'll not start with that theoretically. Okay, but if it's a high likelihood, then CT coronary angiogram is a possibility, but I'll not probably start with that, exposing to radiation to the patient unless I have high suspicion.
Actually, the patient has low probability for this patient. And
so Aziz bhai, Hafiz here.
Yes,
I actually
welcome, sir.
Hafiz.
Yeah, welcome, sir.
So I always like to rev up controversy, right? So we need to think about outside the box, because we read books and we know literature. But question is, first I wanted to remind everybody that this is a patient in front of us and having this problem for 3 years. So what is the question we are asking? The question we are asking, what is the cause of this pain? And to find that out, we have 2 ways to figure out: the physiology and the anatomy. And we have done physiologic tests before, as I was hearing. So, about the radiation part aside, as you know, that the guidelines also has changed and Europeans are ahead of us. In this case, the next question to me is that, is any coronary accounting for the chest pain? And there are 2 reasons for this. Is it anomalous coronary, or is it an early atherosclerosis related CAD accounting for the chest pain? These are the burning question first. And then once that is excluded, then we can think about, whether there is a mesenteric ischemia or mesenteric angina. I don't know. But that story about pain with the meals only, but our presenter, he's a good clinician. He's saying that it sounds like angina. So this all will tell me that I would go for, at this point, a definitive anatomic test, because a lot of physiology already been done, what I'm hearing.
Actually, we need to know what kind of test done so far on her. Did she have any cardiovascular stress testing done?
Yeah. So actually, for this lady, if there is some coronary anatomies, that definitely will exaggerated on exertion.
Mm-hmm.
But if coronary anatomy abnormalities, that will, I don't think that it will be predisposed on a meal. So definitely if there is anomalous origin of the arteries, it course is anomalous, definitely on exertion, on heavy activity, there should be some problem. With minimal activity of the meal, it will not produce any symptom. So in our center, both are available, even dobutamine test, nuclear scan, everything is available. But regarding the socio-economic condition of the patient, I advise to do a treadmill test. It is less expensive and immediately available, rather than the CT angiogram. So our treadmill, when she was put on the treadmill, this is her baseline ECG.
So can I ask you a question?
Sure.
Okay, so this patient is so much overtly symptomatic. I'm going to ask you an oblique question. If the trend, we talk about radiation and we talk about expense, but we need to think about the end game and what is the total accumulative risk of radiation and total accumulative risk of total accumulative expenses. For example, if this patient's treadmill is negative, will you be comfortable to stop there and saying that you do not have any significant coronary or atherosclerotic coronary, anomalous coronary, because of this nature of this patient presentation for last 3 years? I would not feel comfortable even the stress test is negative in this patient. What I have heard.
Yeah, Dr. Chowdhury, if I ask you,
can I put in something?
Yeah.
What Hafiz Bhai is alluding to, that the patient has already undergone different times, different tests, but nothing actually yielded anything positive.
Yes.
So why beat about the bush? Go for the direct kill. That's the point.
No.
Otherwise, she has already spent some amount of money in the last 3 years.
Yes.
So why do not we go for then?
And then I have another proposition for you, and maybe think about this. That if you do a basic calcium score, that will show you the origin of the artery and will show you the calcium plaque. That's it. Okay. If the calcium plaque is negative, Matt Budoff will tell you that you can still have significant coronary atherosclerotic soft plaque. I understand that. But when there is a cost issues, then that may also help you a little bit also, in this situation. Yes. And I don't know, calcium score is very cheap in US. I don't know how much is it in in Bangladesh, and also the radiation risk is very minimum,
Very minimum.
and there is no contrast.
So actually in our center, it is 6,000, same price of the treadmill test. Only calcium is scoring.
Yeah.
One thing, Dr. Atiq, I would like to ask you a question. What kind of test she had it done before that we did not get the clear information?
Only ECG,
Cardiac testing.
only ECG and echocardiography, no other test.
Oh, okay, so she did not have any really functional stress testing.
No.
Okay.
No. This is the first time. So,
did you assess the risk factor profile?
Yes, she is non-diabetic, non-hypertensive, non-dyslipidemic, and no family history of ischemic heart disease.
Therein lies the problem.
Mhm.
Yeah.
So
There is
what we see in the stress test?
Yeah, actually, for me to make sure that nothing is significant in her heart. If stress test is negative, still symptomatic, probably I'll go for the CT angio. But it is immediately available, stress, immediately I can see. So when I put the patient on the treadmill, this is a baseline ECG, dramatic change. And see the second step.
Mhm.
The only 37 seconds.
Patient has left main.
Yeah. And you will be surprised how many
AVR goes like skyrocket in the AVR and multiple lead ST depression. Still our junior doctor continued her for another 2 minutes. This is the chance and then stop. Subsequent ECG in the recovery phase. Gross ST depression. It is still significantly changing almost all the leads.
And I'd like to ask one question. How much drop in systolic blood pressure she had with exercise?
Actually, she did only 3 minutes, less than 3 minutes.
Okay.
So nothing significantly dropped.
Okay.
So these are the things significantly.
Atiq, can we go back to the second ECG? Yeah.
This is the,
Can you describe the points for the youngsters
okay.
that
Baseline,
we should pay attention to?
yeah, baseline, there is some ST just started to baseline. But when she started this stress in just 29 seconds, less than half minutes, there's some ST change in the inferior lead.
This is in recovery period.
Sorry. This is the first ECG.
Yeah, 37 seconds.
37.
Mhm.
See, the first change is there's some ST elevation in the AVR. And there's some ST depression in the inferior lead also in the lateral lead. And see the next one. Just
can we stop it here?
Yeah.
For the young doctors, specialists, please, whenever you see that ST depression that encompasses many territorial areas, because ischemia is supposed to be territorial. It's supposed to be the LAD territory or circumflex territory or RCA territory. Here we are seeing the inferior leads. We are seeing the lateral leads. We are seeing the AVR. So the changes suggest there is a very great change. Either this is serious TBD or it's left main.
left main disease.
We should pay attention to that.
Sir,
And also one question, did she have any symptoms while she was doing it?
Yeah, some discomfort, shoulder discomfort.
okay. Sir, I have a question. If the patient had only ST depression in 2-3 AVF, that means inferiorly, does it have any significance? Only 2-3 AVF, not in anterior AVR or lateral leads. Should we put same importance in those patients?
No. Particularly female patient, no.
No.
There's another important thing that we should remember, that only presence of ST depression in the inferior leads, especially in female. Many a times we rush the patient to cath labs, we've seen, with the change. So, Wadud sir, what is your recommendation in case of ETT? Many a times we see patients are recommended for angiogram based on the ST depression in inferior leads.
Inferior leads themselves, only changes in there, actually have very poor predictive ability for coronary artery disease. If you have change in the lateral leads, particularly V5, that's the most sensitive one, then you can only suggest. Otherwise, most of the time, we do not pay attention to it. and also pay attention to how it behaves during recovery. If it
Yes.
recovers very quickly, you should say
Yeah.
this is negative.
Oh, negative.
And also whether they had any symptoms during doing it. Stress
Then
test.
very significant that is.
Mhm.
So these are the,
I think one point, please. ST elevation also in V1, whether it is a very high risk patient.
yeah,
Yeah.
definitely.
What Shafique is pointing out,
Mhm.
if the ST elevation is in V1 is more than AVR, then it's proximal LT.
Yes.
If it is more in the AVR, then it's left main. Either way, this is very critical.
Critical.
Hafiz bhai.
So that's why I was pointing out that our clinical cardiologist, if the way you are presenting, you looks like you are convinced that this is angina, and if you are convinced that this is angina, then you can still do prognostic purposes you can do Duke treadmill score. But what I'm saying that you need to think about the totality, that what is the next question we have.
Yeah.
We have the question that we need to sort it out. Why this young lady is having chest pain, why it is happening. So that's the biggest question. So I'm not surprised that this happened. But about the ST segment depression, and we need to follow the rules, right? That 80 milliseconds after the J point, upsloping or downsloping or horizontal. If it is upsloping, then it has less importance compared to downsloping or horizontal. And also the degree of ST segment depression is important. And the depression does not correlate with the territory. Inferior does not correlate with RC or circumflex, for example.
Yes.
But ST elevation does correlate with the territory. And ST segment elevation in AVR during a stress test does not have the same importance as otherwise acute coronary syndrome ST elevation in AVR. And in the presence of LVH, that importance becomes even less. But this EKG changes, as someone also pointed out, that the recovery phase, if it is prolonged, that has prognostic significance as well. So this is fluoride positive stress test.
Even after 7 minutes, same changes.
Yeah.
Mm-hmm.
So what should be the...
Yeah, still I'd like to make a point here, because I need to make sure for the trainee physician, please analyze the patient's symptoms. The reason is younger patients, low probability, and having some chest discomfort while eating, not necessarily that we should go for the big gun right away. Okay.
Yes.
So because we need to make sure that we don't get any lesson that, okay, the patient needs to go for, any patient comes with like pain after eating, or that should go for cath. So probability is the very important point. No, just let me finish the point. The reason is the prevalence of disease and probability is a very important point. And one thing is that the patient never had really functional testing per se. Okay, echo is not a functional test unless exercise stress echo or something.
Yes.
Third thing, if you do 100 patients, your yield would be very low, like similar presentation in this patient population. It will be very low if you go for cath everybody.
Yes.
So you really, I think there's a right approach. Going through this ETT first, and we found that, and it's a very simple, low-cost way. We found that. Then we can go more definitive testing. So clinically, always ask the patient how much they exercise, whether they get any chest pain. I'm pretty sure the patient walked a little bit on the hallway in your office would have chest pain. It's only 37 seconds produced the chest pain.
Yes.
So we need to really get the history. I have a good feeling the patient already had unstable angina. If we really got the history from her, then we would not have done the ETT. We would have gone directly to heart cath. If we really could find that information by asking this question to the patient. So collecting history, listening to the patient, and sometimes do some quick walking in the office, even if you don't have the treadmill, and see within 37 seconds, the patient had symptoms. So that's an important point to make, in decision making, what test you're going to do for the patient.
Yes, I totally agree with Dr. Aziz. Totally agree.
Well, may I make a comment?
Sure.
Because we also need to think about the patient, right? What is the
Yes.
usual approach? This patient has having symptoms for last 3 years.
Yes.
And what I heard that it is the question about the pre-test probability and your appreciation about the chest pain. Chest pain is a subjective thing, right? And in the current guidelines, you saw that there's a possible, this atypical chest pain is out. But if you look at the European guidelines, they still kept it. Bottom line is that, is it cardiac in origin or not? If it is cardiac in origin, then the next move and next move and next move, you need to think about in totality. I'm not saying or opposing that you are doing this test is the wrong thing. I'm saying that you can bypass the pathways if you have a good feeling about the patient's history and the question you have in mind. The question you have in mind looks like to me right from the get-go that this looks like cardiac in origin. What should be my next move? So if that comes to your mind, even the stress test is negative, you need to answer the question.
Actually, I have the subjective complaints. If the patient have intermediate probability of the ischemic heart disease, probably I'll go to the directly to the cath lab or CT angio. But very low probability, no risk factor.
Yeah.
I need some objective evidence before taking the patient to the cath lab.
Yeah.
So,
and then I tell you, this is the problem we had compared to the oncologists. The oncologists do not work like pretest probability, like we have been fooled in cardiology, but like Bayes' theorem. They go for biopsy, right? So this is such an important thing in cardiology. We cannot just ignore the stress test is negative, so we are good. We'll have to go, if it comes to in your mind, we'll have to go for the biopsy. And that's, the things will change. In the current guidelines and what we are doing, I know and I agree and we do that, but you need to think in mind that what is the question we have in our hand? If the question is cardiac, then you need to get rid of that question by doing everything impossible. A stress test is not the best way to exclude things.
So,
Ati,
yeah.
Can you put in some facts? Why Hafiz Bhai is saying that? Because if you have single vessel critical disease, up to 40% case, you can have normal ETT.
Yes.
If you have double vessel disease, critical disease, even then you may have normal ETT in up to 15% cases. Yes. If you have triple vessel disease, even then 3 to 5% case, it will be normal.
Okay.
That's what Hafiz Bhai is alluding to. Okay. You have to pay attention as a whole to the whole scenario.
If I take
if you are not satisfied with the outcome, with the result, then you have to give a shot to have an anatomical outcome.
So to say the same thing that Wadud is saying, Atiq bhai shuno, amader surgeon ke, cardiac surgeon ke, আমি কনভিন্স করতে পারি নাই যে ভাই আমার ওখানে আসো 30 সেকেন্ড লাগবে একটা ক্যালসিয়াম স্কোর করতে, তারপরে তুমি চিন্তা করো তুমি স্ট্যাটিন খাবা কি খাবা না। এটা আমাদের মনে এত বদ্ধমূল হয়ে গেছে যে we have not been able to figure out what is the question to us. Is it question is hemodynamically significant atherosclerotic disease, or is it atherosclerosis? What we want to know. If you want to know that this patient has no coronary related disease or no anomalous or nothing, this is all non-cardiac, and I want to exclude by stress test, fine, you are good. But the way she presented for 3 years to me as a clinician, which I think you had the same thing in your mind, there's something cardiac going on. And a stress test, you are lucky. You are lucky actually that you got a stress test positive. In a way, lucky, because now we are going to have a diagnosis, hopefully. But the story is just unfolding. I don't know what we have in store. But importantly, if we say negative, then we have even more responsibility to make sure. And this happened in Bill Clinton. President Clinton had the same sense of, you know, although he had almost no symptoms, that is a different story. But sometimes we ignore people. They had one chest pain, Tim Russell, TV anchor in US, stress test negative, and then somebody said, oh, it depends on who has read the stress test. No, it is not the person who read the stress test. It is the question is what question you had in mind. What was the question?
But if there is low probability before taking the patient to the second step, intermediate probability, probably I'll take the patient directly to the cath lab, but it's a low probability. So I need some sort of subjective evidence before taking the patient to the cath lab. And it was in my mind. That's why I immediately...
I'm not criticizing you, but you can argue that if it is a very low probability, and Aziz Bhai will agree with me, very low probability, the stress test will not make any change in the positive predictive value. If it is high probability, a stress test will not change either. Yes. It is the only intermediate group where the stress test may tilt you towards something.
Now, one point I'd like to make, Dr. Ahsan, that yes, I agree with that. But the question right now, yes, I'm not going to ignore the patient. Yes. And actually, I would have, with the information that I'm getting, if the ETT is negative, I'd have given the CT angiogram on this patient of the coronary arteries.
Same is my view also. Mm-hmm. If it is negative, I'll go for the anatomical test. That is the CT angio. Mm-hmm.
Yeah, and that's why I'm telling you there are ways to think outside the box. You can do a calcium score, you can do a treadmill and calcium score. If the treadmill is negative, I would not be going for CT angio. Actually, I will be going for a CT calcium score first, to save money. Because if the calcium score is negative and the stress test is 10 minutes Bruce protocol, no matter what type of catheter you dance around the patient's eyes, the prognosis is good.
Same, very good. Yeah.
But the calcium score might be problematic in younger patients because they might not yet calcify the lesion.
Yes.
You understand? That's one caveat there.
Aziz Bhai, please don't argue on this.
No, I'm not arguing. I'm just telling you what we're thinking.
No. Listen, we have tons of literature now that in young patient calcium score negative, and if you combine that with the stress test, then the probability of hemodynamically significant stenosis is extremely low.
Yes.
It is so low that
I agree.
that the literature says that you can't make any difference.
Yeah, I'll show the calcium score also. The next question. Yeah. So this is probably the left main origin, left main lesion, RC or multivessel involvement. So I did this angio, and this is the angio. There is a significant, like 95% lesion in the mid RCA, and this is the, if you see the the significant ostial left main disease, like 70%. There's pressure dropout, ECG change, chest pain during the. I did the 100 max of nitroglycerin injection, same result. So decided to the stenting, and this is the stenting after stenting. It is the 4x9 millimeter stent in the left main, covering the ostium also. So very good result. And she followed up after the procedure and totally asymptomatic now, no symptom at all. শোনা যাচ্ছে না, ওয়াদুদ শুনতে পাচ্ছি না। Unmute koro, Wadud unmute.
Hafiz Bhai, what Atiq was saying beforehand, we got very atypical patients. This lady is 48 years old, but we got 28 years old,
39 years only
old,
39,
who have chest pain, typical chest pain with almost no ECG change, and some slight elevation of drop eye. And when we do the angio, we find that ostial left main lesion, only ostial. Everywhere, everything is all right. I don't know why this happens, but we often got this, and all of these patients are female.
Yeah. So there is a cohort that report from Korea, particularly South Korea. You know, we see that kind of disease in radiation patient, oncology patients, right? But in a fibromuscular dysplasia, aortoosteal disease, there is a cohort of patients who may be different than the usual LDL, oxidized LDL and atherosclerotic usual patients, we don't know them. But it is important that we don't miss out these patients. And I always ask my fellows that sometimes if you follow somebody else's history, that, chest pain with food, everybody follows that story, then you need to verify yourself and convince yourself. Put some other oblique questions that, okay, you get chest pain with food. How about walking upstairs? How about laughing? How about coughing? How about this, that? And then convince. And Linda Gillum from American Heart, he said that females present with atypical chest pain, and you call it atypical because you men, you do not understand the women.
Yes. So at the end result is that.
But excellent pickup.
So this is the second case scenario. This is also very young patients, 48 years, who is hypertensive only, non-smoker, non-diabetic, non-dyslipidemic. He went to a sports.
Atiq, I have a question for you. Bhai.
Yeah. Well.
How you are going to follow up this patient? I'm very worried with this lady.
Actually,
that the LDL তুমি বললা ঠিক আছে, কোনো risk factor নাই, এখন secondary prevention কি হবে?
আচ্ছা, secondary তো আমি তাকে dual antiplatelet আছে, still high dose of statin আছে, only this drug,
of course,
no other medication. I'll try to convince her to do a second angio after 6 months because it's osteal left main. Probably she will not agree because financial reason, but hopefully I'll follow her every 3 months, 6 months, as long as possible. And this medication, now she's on Ticarel, is still burden for her because Ticarel is still expensive. Probably I'll try to continue for 6 months, then I will switch over to aspirin clopid and statin only.
Yeah. Will you give colchicine?
That's the point.
I don't know.
Evidence wise, no, probably no.
Probably no.
Yeah.
No.
I agree.
The question right now, what's the reason for her left main disease?
Yeah.
Is it atherosclerotic, inflammatory? That's the issue that I think they're coming up,
I don't know.
Because her LDL is normal, but sometimes those two patients have different other genetic factor like cholesterol ester transfer protein gene problem, hepatic lipase gene problem, lipoprotein lipase problem, ApoA, ApoE, ApoB problem. I'm not sure how, because or just inflammatory. Okay, that we have been discussing because
these are the allies that we should focus, because nowadays we are having many younger population having these sort of problems in the coronaries, and we must do some genetic testing for these patients. Otherwise, this will remain undiagnosed.
These are all these patients all are in my last month's cases, only in the month of July. So
I think go ahead with the second case, please.
Yeah, he went for a sporting activity on the Friday, playing some footballs, and suddenly starting feeling chest pain. Essential, and with excessive sweating, he took shower in the complex, but it didn't subside. So presented to our emergency. And this is the ECG at emergency. Gross ST elevation. Can you someone read for this ECG? Any young doctor?
Let's get from the participants here.
Kamul bhai, can you make Dr. Abdullah Al Mamun from the Dinajpur Medical College? He raised the hand. He wants to answer some question. Can you make him visible? Kamul bhai?
Ji.
Dr. Abdullah Al Mamun.
Mamun.
Dr. Abdullah, Dinajpur, DJMC. Mamun, can you hear me? Dr. Abdullah Al Mamun, can you hear me?
Yes, sir, I can hear you, sir. Assalamu alaikum, sir.
Can you please describe the ECG?
This is 12 lead surface ECG showing normal sinus rhythm. There is a P wave. There is upright position in lead 1, 2, and AVF. And the rhythm is regular, and the rate is around above 100. And there is a ST elevation in lead 2, 3 AVF, and there is a ST depression in lead B1 and lead 2, 3. And so,
Yeah.
my ECG diagnosis is normal sinus rhythm with sinus tachycardia with acute myocardial infarction inferior with posterior extension.
ST elevation.
Probably, yeah, lateral also.
Yeah.
There's television in V5, V6.
B6.
Yes, sir. Yes, sir. There is also extension B5, B6.
So it's ST elevation inferior posterior lateral with the first degree heart blow. So it decided to the right side, and there's no obvious change in the right side. So what to do? This patient want to go home. So he wants to play football and he wants to go home. So I decided, okay, you just admit it. Most likely there is some occlusion of your coronary. Better to identify, and if it is normal, then you can go home. I'll discharge you. So I took the patient to the cath lab. And now it is from here, which one is the culprit vessel here? Before taking the patient to the cath lab, should it be right coronary or the left coronary? Left circumflex.
So the
here,
AVL is not elevated.
yes.
So AVL elevation and lead 1 elevation and P5, V6 will be more in line with CERC.
Sorry.
Although I have a lot of reservation about this criteria, but people talk about it, and this is always an interesting. But in this case, particularly, I'm worried a little bit for a different reason. There is sinus tachycardia, so
Yes.
which is really concerning to me, because when there is a sinus tachycardia with inferior, then make sure that the blood pressure is good. We are not dealing with any mechanical issues either.
Complication. Yes.
Yeah. So I think it's more likely RCA, but I will not bet. I live in Las Vegas. I don't want to bet.
Okay. So I took the patient to the cath lab. This is the first one. And surprisingly, I was more puzzled when I saw this left system. See, there is subtotal on the LED and the diagonal. So what to do?
I think the culprit is the right.
Right, definitely right. So I did the right. It's a full with thrombus, lot of thrombus. I took the suction catheter, though I'm not using too much, but in this case, I opted to do it. And this amount of clot retrieved from the RCA. It's a huge thrombus. After thrombus section, most of the thrombus now in the posterior left ventricular branch, PLV. So I again took the second wire. Wire did not cross the PLV, so I kept in the sub branch and suction given. Then subsequently stenting done. After stenting, still I am not satisfied. Why? There's some haziness here, and there is a big thrombus here in the PLV. But I try to, and there is some here also in the PDA. So decided to leave it here. And then left system. What should be the left? Patient is stable, so I didn't try to do it. I thought maybe next sitting I'll do it. And I kept the patient in the CC with the eptifibatide for 24 hours and see the result. The remaining thrombus in the PDA, PLB, and the RCI. So after next day, I took the patient in the cath lab again. I took the first shot in the right side. It's totally smooth now. All the thrombus gone. I have a plan. If there is still thrombus, still here, probably I'll send the patient for the surgery. But as long as the right system is very clean, so I decided to do the left system, and it was done. Initially, I thought maybe bifurcating nation should I go for the double stenting, but my study is single provisional. So I did the POVA to the left system diagonal, and this is the end result. Good result, I think so. So he is doing fine. Already after 2 weeks, he came to my OPD also. And this is the ECG after 2 weeks. And he started his job again. Want to start football?
Sir.
I told, yes.
Sir, was the temporary pacemaker given plannedly, or it was any event that led to do
Actually, I was not planning to put it. I don't put the pacemaker in a RC lesion or majority of the case I do without pacing. But when I saw the left system is so critically diseased, I thought maybe patient can crash. So I decided to put a pacemaker, and I punctured the femoral, and I did the PCI through the right radial, and hopefully it was nice. Patient tolerated the procedure. And subsequently, after 1 day, I did the left system, and pacemaker immediately removed from the cath lab. This is the ECG after 2 weeks. And
whether patient having any history of COVID recent past?
He had COVID maybe initially, almost 1.5 years back. Not now, more than 1 year back.
But in the meantime, there's no history, fever,
No.
anything.
Nothing. He's playing football every week. There's a big group. They are playing football in a Purvachal nearby. Every week he's playing football. He wants to still play football. I told her after 6 weeks, maybe not now. So probably he is doing fine. Only a young patient. And this is also very interesting patient. 38. All are below 40. He presented with chest discomfort and heaviness for 1 day. His risk factor is only smoking. This is his first ECG in our hospital. Who can read this ECG?
You can ask the attendees.
Attendees, yeah. Junior doctors.
Kamrul, can you make Anjumanara, Dr. Anjumanara a speaker? Dr. Anjumanara has raised her hand. Kamrul.
Assalamu alaikum, sir. This is a 12 lead ECG showing heart rate.
Introduce yourself.
75. Okay, sir. I'm Dr. Anjumanara, cardiology thesis participant from Dhaka Medical College. This is a 12 lead ECG showing heart rate near about 75 beats per minute. Rhythm is sinus and regular. There is a T inversion in 1 and AVL. And otherwise it is normal ECG, except there is a ST depression in 1 and AVL.
What about this tiny Q in the lead 2-3 AVA? Very tiny, non-pathological.
Non-pathological, so not significant. I mean, আমার কাছে স্যার significant মনে হচ্ছে না.
Left posterior hemi block.
What about the relatively tall R in V2? And the T wave is very prominent in there.
Yes.
Yes, sir. True posterior MI হওয়ার সম্ভাবনা আছে.
Even the lateral lead V6 also, TST is little bit depressed. V5 also depressed. So not too much change. This is the next ECG. It's still same. But this time lateral lead V4, V5, V6. ST is more prominent. ST depression. So his troponin was very high. That's the things I took.
Can you go back to the previous EKG just one time? And let's look at the V2 lead and go next. How the way the terminal complex, I mean ST behaving differently.
Differently. So decided to took the patient to the cath lab, and there's some change diagonal, but surprisingly, this is right coronary.
It's totally occluded.
Totally occluded. Surprised me even also.
I was thinking more on the left circ somewhere.
Yes.
Okay.
So it's
But
it really
in lead 3, there are some certain like slight ST elevation starting in the first EKG, with previous one.
Yes.
Oh, that's one. Yeah, you see a slight change that I noticed, but it's still with one lead we could not say much.
Yeah.
Okay.
Here also looks like little bit.
Yeah.
Very 0.5.
Very subtle. Very subtle.
So
Yes.
subtle.
Mm-hmm.
So this is the year. It surprised me. So I did the stenting immediately, and this is the result.
I think whether there is any source of retrograde there.
Yes, retrograde there.
That is why the ECG is not.
There is.
It's not that significant changes.
There is the retrograde. Here. You see the retrograde here.
Yeah, that's collateralizing. Yeah.
Yeah, collateralizing.
Mm-hmm.
That's why there is no probably some changes.
Mm-hmm.
I think what was the troponin level?
1900 something, around 2000.
That's the high sensitivity troponin.
High sensitivity, yes. So this is the post PCI ECG, this patient. Now there is clean cut Q wave in the inferior lead. It was not there.
Sir, many
Yes.
times people ask question that before doing PCI there was no Q, but after PCI there appears Q. So whether at all there is any benefit or not, or that part is already dead, because Q means dead tissue.
No.
So can you, sir, please
It
clarify?
can be for different reason also. Definitely ischemic changes, necrosis is one of the reason. But other than that, it can come. During acute ischemia, probably there is some stunning of this muscle, but subsequently once you revascularize, it will gradually participate in the pumping process and it will be normalized, definitely. So very interesting. No correlation with the ECG, the coronary angio finding. This is also very young patient.
I think the point,
Yes.
I think one physician made that because of the collateralization that we need to understand, because significant collateralization, that's why they mask the RCA induced ST elevation that we expected.
Yes.
Yeah.
It was not there. PDS well collateralized from the left system.
Yes. Mm-hmm.
That is the reason. So this is a very young patient, 38 years, male, hypertensive, dyslipidemic, who presented to our hospital. Before coming to hospital, he was admitted in Sylhet with chest heaviness and subsequently came to our hospital. This is EKG in Sylhet. It was absolutely, I think, normal. Can anyone see any problem in this ECG?
I'm cautious about inferior leads, but I'm not going to comment on that anything serious. Okay, but I'm keeping an eye on that.
Yes. So
Lead
once
to-
he came to our
Mhm.
hospital, this is
Mhm.
first ECG in our hospital.
Okay.
There is some gross STT change by physic and up to V4. And the same
Just
day,
well in CKG.
yeah, and the same day, there is another ECG, totally normal as almost.
That
Now
is
it
more
is
dangerous.
dangerous.
Dynamic tube changes.
Dynamic change,
Okay.
some occlusion,
Yes.
occlusion, reocclusion process is going
Yes.
there.
Uh-huh.
So this is the third ECG in our hospital. Again, change.
Needs
And
to go to the cath lab.
Yes. I took the patient to the cath lab. And which one is the culprit vessel? Probably everyone knows. So sequelae of the OLH syndrome, sudden complete occlusion in the LAD, transient anti-ST change, ST elevation, reperfuse start, normalize, but T-wave become inverted. If LAD again reoccluded, T-wave this time may be upright and pseudo-normalization. So this patient have all the sequelae of these changes. So I took the patient to the cath lab. Right system is okay. If you see the left proximal LAD, and there is a huge calcification. This very young patient, but heavy calcification outside the LAD, flex of calcium with the critical lesion in the LAD, like 95%. And very distal LCX. So young patient, but significant calcification. So decided to do the stenting, and it was done. And this is the end result. So this is the end result. So young patient, but having significant calcification, but mainly calcium in the outside, adventitia. So flex of calcium with significant proximal LAD lesion and significant ECG change, OLN syndrome. If we look back the ECG before, this is the last ECG before taken to the cath lab. This is normal as almost. This is the first ECG in our hospital. This is the outside hospital.
So serial ECG is very important.
Yes.
Yes, actually, this is the very thing that we normally miss. Unfortunately, if you don't really listen to the patient and examine the patient and get the clinical history, because the patient has been having occlusion and reocclusion, occlusion and reocclusion. What's happening that we have our own fibrinolytic system in our body that tries to dissolve the clot, and they open up and EKG normalizes or looking normal. But if they can reocclude, and particularly the Wellen types EKG, if you see them, this type of EKG, this is like type A is going to convert to type B when a deep to inversion. So these are the EKG you should never miss, because they inevitably will have acute ST elevation MI in the long run. And their chance of death, mortality, morbidity is very high. So these patients are really on the high in the agenda to take to the cath lab after the STEMI, but that's if you look the grading, but this is just, they require immediate attention like the STEMI people. Because I won't put the patient for the next day, I'll probably take to the cath lab right away if I see this EKG.
Yes. This is the EKG before taking the patient to the cath lab.
Mm-hmm. Mm-hmm.
He still didn't come, came to the follow-up. Probably next week he will come. But I'm surprised the amount of calcification in the LAD, it really surprised me. And risk factor is only hypertension.
Now, this is very important. I think very nice presentation that you're showing younger population, very focused younger population.
Yes.
I think the data we are getting mainly from Asian population on that, because the United States we get about 1.2%, like below age 40 in that rate, dimension if you do the statistics. But in Asian population, particularly in Indian population, Indian subcontinent, it's 10 to 15%. I think that Dr. Agarwal published, I believe in 2016, Amit Agarwal, I'm not sure which institution from India, but 10 to 15% population they see in younger generation. The question right now, we need to really look at genetic testing on them. They most likely have, they might have LDL okay, but there are other lipid genetic testing could be abnormal. Like CETP and then a different type of lipoprotein, ApoA, ApoE, ApoB, because difficulty is going to happen. How are we going to manage those patients post-procedure? Definitely we probably have to do the statin that we have in our arsenal because we don't have any other that targeting to other specific other lipid derangements. And still we're in the phase of finding those drugs that might affect that particularly different kind of other genetic abnormalities. Okay, so still a statin drug would be the drug of choice still that we have in our hand. But we cannot ignore those patients because we see in Indian population particularly, and another factor could be that genetically, I was told, and I believe that's probably true, that their diameter of the vessel is smaller than European population, okay? And this is another factor might be involving the shear stress, the way their blood flow going there, and making some more atheroma down there. But also another factor that Dr. Chowdhury mentioned earlier, that for the inflammatory disease, something causing the problem also, inflammation in smooth muscle cell proliferation and causing the non-calcified atheroma, that we call it, build up in the dystopic patients. So still a lot of, I think, research needs to be done. And I would encourage Dr. Atiq, please collect those patients, and it's good for publication. Okay. It's really, you have like already several patients, looks like. And an interesting database, specific for our Asian population, like South Asian population.
Thank you, sir. This is another younger patient. Right now, he's 40 years old, normotensive, diabetic, positive family history. His father died at the age of 46 due to sudden cardiac death, SCD. So he first presented to our emergency 5 years back with sudden cardiac arrest. At that time in the emergency, his rhythm was showing VT-VF, CPR given 30 minutes, 15 times DC shock, intubated. And I took the patient to the cath lab, 2017. He survived, did the PCI to the primary PCI to the LED and RC in the same setting. And he was doing reasonably good. Just few days back, he came to my OPD. It was a Thursday afternoon with some heaviness in the chest for 2 hours duration. And he's regularly following. And recently he started smoking also. We missed it. He started smoking. So this time I did the ECG at the OPD. This is the first ECG. Who can read this patient? He had an old MI before. PCI done to the LED, 2017. This changes before also.
Kabrul,
so who can read?
Dr. Naeem. Dr. Naeem.
Assalamu alaikum, sir. In the surface ECG,
introduce yourself.
Heart rate is.
Dr. Naeem, can you please introduce yourself first?
Sir, I am Dr. Naeem from Rani Shankar Upazila Health Complex, medical officer. Sir.
Excellent. Thank you, Naeem. Please carry on.
Sir, this 12-lead surface ECG with proper speed and proper voltage, with proper lead placement. Their heart rate is 48 beats per minute. There is no P wave in 2-3 AVF. The rhythm is regular, and there is ST elevation in 2-3 and AVF, and ST depression with T inversion in 1 and AVL. Also, there is T inversion from V1 to V6 and Q wave from V1 to V4. So the rhythm is junctional rhythm, bradycardia with junctional rhythm, possibly inferior STEMI inferior and old MI anterior.
Excellent.
And please look at, there's some P waves, carefully look at it and
Yes.
see if there's correlation, how close they are with this.
Yes, sir. That appears after towards the end. So
Yeah.
initially there was no P, but just towards the end of the rhythm strip, there appears a small P wave. The last two beats, they are preceded
Yes.
by P wave, but other than
Yes.
that, it
No.
was junctional, basically.
So this is the ECG immediately after admission in the CCU. Just few minutes. Same chance. So heart rate brady and ST elevation in 2-3 AVM, QF long before also. And this is another ECG, same patient. So which one is the culprit vessel here?
Marfa Rahman. Kamrul, please make Marfa Rahman speak. Kamrul.
Can anyone?
That it could be RCA, as there is ST elevation more in 3 and AVF, and ST depression is more in AVL than lead 1.
So ST elevation more in 3 than the 2, and reciprocal change more in AVL than lead 1. So inferior MI with ST depression in V1 to V3 is more often associated with LCX, and particularly if it is the lateral lead like V5, V6 or 1 AV, it is more with the LCX goes. And reciprocal change, ST segment depression in AVL predict LCX occlusion also. Ratio of the ST segment depression in V3 to ST segment elevation, basically we are not doing this. In 3, more than 1 predict LCX occlusion. So the ROF in V1, it is more with the RV infarction, highly suggestive. So LCX occlusion, and we took the patient to the cath lab. See, there is a subtotal occlusion, the LCX here. The caudal view will come more also here. The caudal view it is showing here. Also here. Sorry. Right is almost except the PDA, it was stated before, but after the stent there is some lesion here. And also one lesion here. So we decided to do the LCX first. And I didn't put the stenting slide here. So I did the LCX as a primary lesion, and then I put 2 stent here also in the PDA, and 1 also here also in the mid segment. So these are the 5 cases, all very young patients. And ECG correlation with the cath and also the findings also. So what should be our take-home message from our today's discussion? ECG is definitely a very important supportive tool to diagnose ACS, but not always helpful, definitely. History is the most important part. History is very, very important, crucial part. If there is typical symptom, typical history, probably you don't need any other test. And lab parameter, particularly the high sensitivity troponin, it also makes our life easier to diagnose in acute coronary syndromes. But the last one is very much lacking in our country. No one is referring any patients until death. So timely referral to a cardiologist is very vital for proper management. And hardly you will find any patients anyone is referring. And once they are in trouble, like cardiogenic shock in the terminal stage, they used to refer for their shoulder shape, back shape. So most important part is definitely history for me. Whenever you diagnose the patient, other than ST elevation MI. Thank you. So any comments, any further discussion?
Thank you very much, sir. Before we going to go for discussion.
Atahar bhai, will you make some comments?
Yes, Atahar sir. Atahar sir was kept quiet all the time.
Dr. Atiq, can you stop your screen share, please? Congratulations and thank you, Dr. Atiq, for your beautiful and excellent case presentation, particularly from the young patients, and inviting excellent discussion. Particularly, I want to thank Dr. Azulhaq, Chowdhury Hassan, Abdul Chowdhury, and some of our young participants from the event from the Upazila Health Complex. So excellent discussion, Atiqur Rahman, excellent. Beautiful case presentation.
Thank you, sir. Thank you.
Chowdhury. Achha, here is Rafique, sir. I can see Rafique, sir.
Yes, sir is there. Yeah.
And,
Sir is there, sir. Sir just reached, I guess. Sir was outside. I think he has just reached home. Rafique, sir, can you hear us?
Yes, yes. I followed half of it. Good presentation. Good case. Thank you.
Sir, are you on hiking or something like that?
Alaska.
Oh, Alaska.
For hiking.
For fishing.
Sir ke baat করতেছেন
রফিক ভাই আপনি নাই বলে ঝগড়াটা আজকে আজিজ ভাইয়ের সাথে লাগাই দিছি
হ্যাঁ ভালো
It's okay, nothing wrong.
আজিজ ভাই সাধারণত ঝগড়াটা রফিক ভাইয়ের সাথে লাগাই আমি
No, it is beautiful discussion. Actually, this discussion really encourages our young patients to understand how we come to the logical conclusion, what's the best approach to the patient. Okay,
absolutely.
Because it's not like because even sometimes when around with my fellows, I was thinking different way, and I'm giving some more information from the fellows. I agree with the fellow, because they are giving us more logical explanation. So I never think that I'm absolutely right, okay? But I'll always like to have explanation, understanding, discussion, and what's the best option for the patient. That's the approach I think we would like to introduce from our forum to our community down there, for the young physicians that develop that type of mindset to understand and logical, decision-making process. Not like that I'm always correct. Absolutely not. I always think I'm not correct. And I want to get information from others, then it helps me better to approach to correct decision making, particularly for the benefit of the patient. Absolutely.
Aziz bhai, you are always right. But my question, I just wanted to discuss that there are many ways to sort out an issue.
Absolutely.
And I
Definitely.
congratulate Dr. Atiq Bhai. You did excellent because you did not stop. And imagine losing a young patient like that is really very shocking, you know. Okay, 3 years she was going around. But
And
your second patient was more challenging.
Yeah. It was, I was puzzled also. The Friday, no help, no surgeon, nothing is there. Only Atahar Ali came at that time to see his patient, the primary PCI, that patient.
Well,
So-
Atahar Ali was there because you had a temporary one.
So I thought it's a smooth case, only right side or maybe LCA. But when I saw the LED subtotal with the big diagonal, also subtotal, bifurcating lesion, I thought maybe patient will crash on the table. But alhamdulillah, he's.
By the way, if the fellow says that, well, we need to look at the LAD and go after the LAD, I will politely tell this fellow, scrub out of the case. Because clearly the target culprit lesion is the RCA.
Yeah, and the huge amount of thrombus. Rarely we find this huge amount of thrombus in the aspiration. It's a
And just to let you know, we are using lately the cangular compared to eptifibatide. Yeah.
Okay.
Maybe we can advise some of the companies to bring cangular because it is much easier for starting on and off with the half-life so low. And but I noticed that you still use the radial and then went from the groin for the temporary. Right?
Temporary, yeah. Temporary.
One point I'd like to make in this case, Dr. Atiq, that this is a very important topic you're presenting to our young physicians, because we have guidelines, yes, but guidelines is for standard patients and standard like pre-test probability, post-test probability, and all these things. Despite that, we analyze those things. Still, we have some difficulty in female patients, particularly. Yeah. They have atypical presentation, atypical presentation. So our analysis should have high radar, so that we should accept the signals that we should miss from the patient's history, physical, and surroundings things. Because if the patient having symptoms, we should not ignore it. But nowadays we have a very good approach, like cardiac CT, coronary angiogram CT. Really, as you know, that there's some new data showing that some patients, if like synergy, trial and other things, that we need to really look at, just if you have suspicion high enough, do the coronary CT angiogram, and then you can go further. You understand? Okay. So, but in this case, I think you did the right thing, and I would have done the same thing, But we still have difficulty understanding female patients sometimes, because they might have like vasospasm, that they might have microvascular ischemia. It's very difficult to understand. Some people might have, we might miss sometimes myocardial bridging. We might miss those, but they're having symptoms. So these type of things that make us alert to really listen to the patient, and not to if stress is negative, I probably would not stop there. If the patient is still having symptoms, I'd have gone further. So that's kind of a teaching point for our young physicians. So listen to the patient. If you think it's suspicious for coronary, go further. Don't stop there, just routine treadmill.
At least you need an anatomical diagnosis at least. Once your anatomy is okay, then probably safely you can send the patient home. Dr. Wadud, any other comment, discussion?
One thing is that whatever you do, if we do not take a very good history,
yes.
And sometimes I wonder, this patient has gone from doctor to doctor. They have given some, I think, antacid or something like that. If it doesn't work for the lady, so why should not you think otherwise? What you have done here? That's what we should think. The guidelines are talking about standard people, and this is an atypical patient. Why are you repeating the same medicine? The same mistake I see the people are doing, going from one doctor to another and giving the same medicine in another brand and something like that. You should not do that. You should think that there could be some other possibilities. That's what
you're right.
Hafiz Bhai and Adit Bhai was alluding.
And the reason is, if you're in a computer, in the programming, if you give the same information, computer will give the same output. You understand? So you need to get new information, new history, listen to the patient and think differently because patient's not improving her symptoms.
Actually, I was trained mainly in the Saudi Arabia where resources abundant, unbelievable resource there. And legal things very strict. So I saw someone is writing in the emergency sheet, there is a right bundle block, something like a fishy, so Bugada. Until you clear that there is no Bugada, that patient will leave the hospital. If you will come next morning, they will do the asthma test, all the tested, and find there's nothing wrong, then the same. So once your legal thing is very strict, probably you will not send the patient until you are sure that he is safe, he or she is safe. But here in our country, loosely we are putting some antidepressant, some PPI, lot of things, because legal things are not there. If still legal things catching the doctors, probably no one will do that things. Everybody wants to save his skin.
Can I make a comment, please?
Sure.
Yeah. So two things. One, even in America, female patients were ignored for a long time. That's known fact. Second is the history taking. And it's the repetition of the same history taking doesn't help. You look at a patient, chest pain, that's one line, doesn't work.
Yes.
So, and the other thing is that it doesn't matter how scholarly you are, you cannot take a history in 2 minutes or 3 minutes. You have to give time. So that is the other issue. It has nothing to do with the legal part. Legal part is not when you have entered the field of medicine, you are supposed to do a job. And that job, I hear this argument all the time. We have too many patients. I have too many patients here also, but I will not take too many patients. I will only take the amount I can see. That's one part is so important, the history taking and the detailed history taking, especially somebody who is going from one place to another. And somebody have to find out what is the story and really carefully take a clinical history, and that will really pick up those patients. Thank you.
Probably this part is also missing in our study in Bangladesh also. Nowadays, everyone is depending on the machines and other things. But our old teacher, they used to take, okay, just go to the patient, beside the patient, bedside teaching. Probably these things are no longer working in our country. I think so, because nowadays, everyone is ordering only investigation, like North America we are following. And that's why you are taking the patient to the cath lab. Severe aortic stenosis, nothing is there. Patient came immediately, some ACS. You do the PCI and subsequently diagnose the severe aortic stenosis. If you put a murmur, if you put a stethoscope, you can diagnose.
Yes, absolutely.
Atahar, will you wrap up?
Yeah. Yes.
So after you wrap up, can we stay for a few minutes?
Yes, sir.
Yes, sir.
So, Tushar, actually,
Okay, sir.
I'm
Sir, usually we stop here. Atahar sir will wrap up the session. Then I request Chowdhury Ahmed sir, Abdul Wadud Chowdhury sir, Rafique Ahmed sir, and Ajit sir to stay for a while so that we can discuss about the programs that are going on and our future planning. Atahar sir, please wrap up the session for the time being.
So, Atiqur, thank you very much for your excellent case presentation today and introducing and inviting the beautiful discussion in encouraging our particularly some junior participants. Thank you very much for your excellent and nice case presentation. And really, it was I don't know how did you do it. Besides my side room, I don't know how did you follow the cases. That is the serial ECG is collected for the last 3 years. Excellent job, Atiq. Thank you very much for your excellent presentation today. And I'm wrapping up the session and requesting to just stay a few minutes, Professor Chowdhury, Azulok, Chowdhury Ahsan, and Rafique sir. So, Kamrul, you can lead the other participant.
Yes, sir.
Thank you, sir.